All right, great. Thanks, everyone. I feel out of place. I'm the first American who's speaking here today. I hope you guys will accept me.
Make an exception.
Okay. So I have no disclosures. So, I mean, a lot of the things that I'm going to talk about have already been touched upon by our previous speakers, but there are a lot of different outcomes that you can look at in measuring for an ERAS program, physiologic outcomes, complications, length of stay, readmissions, quality of life, cost savings. Again, many of our previous speakers have already spoken about these, and I'll just touch a little bit more about some of them. So, you know, when we're looking at the different outcomes that you can measure or would like to measure with the implementation of an ERAS program, you have to think about who actually cares about those outcomes. And of course, patients, we hope, would care about those outcomes, particularly if they feel better after surgery or if they can get out of the hospital better or can recover better. Healthcare providers, as all physicians and nurses, of course, want their patients to do better. Of course, hospital administrators want patients to get out of the hospital better and have lower costs, as we just heard about. And then regulatory organizations, CMS, other payers that also would like to decrease the amount of money that they're spending on patients. So a lot of people are invested in this. I think Leanne talked about this earlier, but as far as the physiologic outcomes after as a response to ERAS surgery, I mean, there's just probably so overwhelmingly amount of evidence that proves that, for example, just one aspect is the feeding patients prior to surgery can decrease the surgical stress response. So it decreases the patient's thirst, anxiety, their postoperative nausea and vomiting, insulin resistance, increases their muscle strength. I mean, this has all been shown time and time again, yet again, as we've just noted by our audience here, most institutions, for whatever reason, still have not implemented that. It's really important to patients because, of course, they don't want to be nauseous after surgery, and no one likes to be NPO for a long time. And it's also really important to surgeons, anesthesiologists, and nurses because they have to take care of those patients. So again, these are all outcomes that we're interested in. As you know, the point is why are some of these things so difficult to implement? And you know, it's a very multifactorial issue. Other outcomes that, again, a lot of these have been talked about, but for example, complications. So there are general complications, surgical complications. Of course, everyone wants to decrease complications, patients, healthcare providers, administrators, and organizations, because then they have to pay for the patient's complications. So these are all really important. And this study has been shown a couple times already, but this was a meta-analysis of a whole group of randomized trials for comparing ERAS to traditional care just for colorectal surgery, looking at complications, mortality, hospital stay, readmission rates, and looking at overall postoperative complications and then just specific surgical complications. And basically, again, you can see that the enhanced recovery programs decreased the general complications by about 30%. There was no difference in surgical complications. Again, just proving that this is definitely an effective program. Again, hospitalizations, like length of stay and readmission. Of course, one of the first things that people said when the ERAS programs were first getting implemented is like, well, if you're going to kick your patient out of the hospital sooner, doesn't that just mean that they're going to get readmitted and they're going to have problems at home? Well, that's, of course, really important to a lot of people, but that's already been shown by many studies not to be true. So going back to the randomized control study, they were able to show that the ERAS programs definitely decreased the overall hospital stay without changing the readmission rate. So again, just another piece of evidence in many studies that has shown this. Again, this is a meta-analysis that looked at a whole variety of ERAS programs, so colorectal, orthopedic, urology, upper GI, thoracic, again, showing that the enhanced recovery programs throughout the board for all the cases decreased the length of stay, again, without affecting readmission. So in fact, implementing these programs, getting the patients out of the hospital faster does not mean that they're just going to get sick and get readmitted right away. Economic benefit. So we just heard a whole talk about economic benefit, and there's a lot of things that go into economic benefit. So for, not only hospital cost savings, but there's different societal costs. There was a study done by Dr. Lee, I'm going to talk about in a second, that shows there are some very interesting things that you can look at as far as economic benefit, other than just direct costs to the hospitals. So again, this was a study done at McGill. They compared an ERAS program to conventional surgery at 2 different institutions, and basically looked at cost effectiveness. So there, again, if you can see the top, you can see the hospitalization was reduced without increasing readmission. But then there were some really interesting things that they looked at. So for example, how many days that were lost of work for the patient. So you can see that in the ERP patients, they had less days lost from work. And then how many days did the caregiver actually lose from work? So you can see that even taking care of patients, that also decreased as well. And so that also translates to an overall societal benefit. Again, just looking at direct costs, you can see that the overall institutional costs were decreased, as well as the healthcare system costs, and then societal costs, which include some of the things that I just showed you in the previous slide. So these are things that some of these are a little bit easier to measure, like direct costs, but the things like societal costs, a little bit more sort of fuzzy, but actually really important. And now we're going to get to some of the real things that are much more difficult to measure. So things like patient satisfaction. I'm sure you're all aware of the HCAHPS scores, as well as Press-Gady scores, or different hospitals use different things to measure patient satisfaction, but that actually turns out to be not so easy to measure. And then really much more sort of fuzzy things like whether or not patients and or providers would accept ERAS programs or their perceptions of ERAS programs. So this was a study from Johns Hopkins. This was an interesting study. I actually was still at Hopkins when this was going on, so I actually was able to experience this firsthand. But basically, what they did was implemented this integrated recovery pathway for surgical patients. And to do that, they started with something called the comprehensive unit-based surgical safety pathway. So basically, this involved really buy-in from everyone, from hospital leadership down to providers to patients, and everyone up front came to the table. Everyone was in service on what was going to happen. Everyone had a lot of buy-in into it. It really required a tremendous amount of support, primarily from hospital leadership, because one of the main things that they did was, first of all, limit all the patients that were going to be part of this pathway, so that they would have the same nurses and the same team in the operating room. That included the techs, the nurses, even the anesthesiologist and or the CRNA. So that was one thing, that everyone was on board with the same pathway there. And then after surgery, all the patients would go to the same unit, so they'd all be on the same floor, again with the same nurses on the floor that were taking care of the patients. So, I mean, it was really great for the patients. It was also great from the provider standpoint that you knew you were going to have the same people all the time. So again, that's a little bit harder to get your institution to agree to, but if you can get to do it, again, like I can say from firsthand experience, it's really very beneficial. And so what they were able to do is, first they implemented just sort of that CUS program, and then you can see that the things that are easy to measure, like surgical site infections or urinary tract infections or venous thromboembolic events. So you can see that just after the implementation of the CUS program, you started seeing a decrease in those events, and then afterwards then they implemented the actual ERAS protocol, and you can see that it continued to go down. So it's sort of a two-pronged approach, not only having everyone on board as far as the CUS program, but also the ERAS program. And then again, of course, they were able to show that the length of stay decreased and the cost of the hospital decrease. If you looked at the HCAHPS scores for these patients pre and post implementation of the pathway, basically they all improved in all of the domains. So it turned out to be a really sort of positive program. This is another study. Again, this was just in colorectal surgery after implementing a standardized protocol. And again, the things that we all sort of expect now, so you can see that the length of stay for the patients were shifted to the left as compared to NSQIP, and you can see that the ERS program, the colorectal patients had a much higher length of stay compared to the overall length of stay in the hospital, and then it decreased afterwards. Again, those are the things that are easy to measure, but then again, when you looked at the Press-Ganey results for these patients, one of the things that basically, again, improvement across the board, particularly in things like you wouldn't think about. So for example, like nursing responsiveness to the patients, or nursing friendliness, or whether or not patients felt like they were ready to be discharged from the hospital. So all really, again, much harder things to measure, but all really important. And then if you want to go into like the really sort of fuzzy things to measure, again, attitudes of patients or providers to these programs. These are, again, much harder to actually give you direct data on that compared to, for example, length of stay or complications. Again, this was a European study and from 3 countries, Scotland, the Netherlands, and Norway. Again, they basically sent out surveys to patients after all sorts of surgeries, not just colorectal, so any major abdominal surgery, and they send it to patients and to their providers. And basically what they were looking at was what aspects of the ERS protocol did the patients find most important, and whether or not that corresponded to what the providers thought. So that and basically you can see that, so the things that patients and providers, happily they corresponded for most things. For example, things like the freedom of having postoperative nausea or vomiting, or actually to be completely free of pain at rest. Those were things that were the most important to the patients, again, and also scored very highly by the providers. And then as far as the strategies for the ERS protocols, the preoperative counseling was by far the highest scored by patients and providers. And again, you can see that for all of the aspects of the ERS protocols, there was, in general, very good acceptability. And then this is just a final study that I'll go over. Again, this was another study that was done at Hopkins. Again, just looking at outcomes and then also the provider perceptions following implementation of an ERS program. This was for open liver resection. At Hopkins, they started with the CUSP program and the ERS programs for colorectal, as is in many cases, and then they started translating it. Then they did pancreatectomies, and then most recently the liver resections. And again, they looked at variables pre and post implementation of the pathway. Again, you can see that there was costs to the hospital, things like pharmacy costs, laboratory costs, medical supplies. Those are pretty easy to see why that would happen, because if you have a protocol on when you're going to draw labs and what studies you're going to get, it makes it you're actually able to eliminate a lot of waste that happens. And then again, if you look at the survey on what the providers felt about the pathways, there was basically about a 91% acceptance by all the providers involved in the ERS protocols about the different aspects of the protocol. So basically, again, there's lots of evidence that shows that ERS programs can improve outcomes in all sorts of domains. The outcomes that you are measuring are very important to lots of stakeholders. Some are easier to measure than others. And then again, I think as more and more data becomes available, I think more hospitals will be more willing to adopt programs. And again, we'll hear a little bit more about that as the rest of our speakers come along. So thank you.
Great.